I'm Dr. Lawrence Nair, Associate Medical Director of the National Emphysema Foundation, and today I'm going to be talking about chronic obstructive pulmonary disease, COPD. COPD is a very common disease, and it is the fourth leading cause of death in the United States, and it will soon be the third highest cause. It's a very costly disease as well, as it affects nearly 16 million Americans that we know of, and there's probably another 16 million who are not diagnosed yet. It's a silent disease in that it takes root before we can know, or before we know that we're symptomatic. It has already caused a lot of problems. And also, it's a disease that's occurring more frequently, in that it's usually diagnosed in the 5th decade or later of life, and since our population is tending to grow older and having more people in that decade bracket, we are going to see more COPD as time goes on. COPD is essentially described as airflow limitation. And what happens is inflammation, be it from cigarette smoking, inhaled substances from the environment, or diseases such as alpha-1 antitrypsin deficiency, cause irritation and inflammation. And in the lungs, this in turn will cause airway narrowing, which is due to swelling and mucus production. In addition, destruction of frank lung tissue occurs, so there's less surface area for oxygen and carbon dioxide to exchange between the air and the blood. This, of course, is the primary function of the lung. There's also what is referred to as a decreased in elasticity. Elasticity is the ability of an object to be stretched and then go back to its natural state. An example of elasticity is a balloon when it is filled up and then the air is let out. In a patient with COPD, the lungs are less elastic, so it's less likely that they will naturally be able to go back to their resting position. What this means is that a patient must have to push the air out. Therefore, between the narrowing of the bronchial tubes and the increased work of breathing needed to push the air out, the patient with COPD feels the sensation of dyspnea. Now, the diagnosis of COPD is based on spirometry, where one would have an FEV1-FVC ratio graded as less than 70%. However, most people with COPD are recognized before they have their spirometry. Traditionally, there are two types of looks to a person with COPD. One of them is the husky and burly person with excess phlegm. This is known as the chronic bronchitic. These people have cyanosis, a lot of rhonchi, wheezing and crackles on their exam, and excessive mucus production. The other type of patient typically described is the skinny, barrel-chested pink puffer. This is the patient known to have classic emphysema. The pinkness means that the patient is getting adequate oxygen. Mostly they have shortness of breath. Now, in the hospital, the nursing assessment is something that will come into play in all these patients. Typically, an uncomplicated case of COPD will have the patient come in, receive the treatment, and he will feel better the next day and will get progressively better until discharged. However, there will be times when there will be dyspnea that will need to be assessed. Certainly the initial nursing observations are very important to use as a guideline for when these periods of deterioration occur. Now, in general, we always would check initially for the airway and the breathing to make sure that that is okay from an ACLS standpoint. The patient will sometimes be very anxious, and it'll be up to you to assuage their anxiety and to tell them what you're doing as you are assessing them. In addition to this, positioning of the patient is very important, and just from your inspection you can see if they are sweaty or diaphoretic, if they're using accessory muscles, if they're sitting up in such a way called tripoding where they're trying to gain maximal muscle leverage, and if you see accessory muscles in the neck being used, as well as abdominal paradox. Usually the chest wall and the abdomen move out together as somebody breathes. With abdominal paradox, the abdomen may move out, but the chest wall will move in. And this is a sign of impending respiratory failure. Now, in real time, the patient will not say, I have COPD and I am short of breath, and you treat COPD. There are other possibilities as to causes of shortness of breath, and when you do your assessment, it helps to tease out some of these factors. For instance, if there's a positive fluid balance and there's worsening crackles on your exam, and there may be wheezes as well, then one needs to think of congestive heart failure. If there is chest pain and new arrhythmias, ischemia may be an issue. If the patient has sudden dyspnea and worsening oxygenation, then pulmonary embolus could be a new complication. Sometimes patients with COPD have sudden sharp chest pain or shoulder pain and possibly new unequal breath sounds. One needs to consider pneumothorax at that point. Oftentimes the patient will have a new fever with a high white cell count and purulent sputum. In this case, a new pneumonia may have occurred. Sometimes the patient is dyspneic, but there's no change in saturation, exam, or ABG. They may have had previous displays of nervousness before, and sometimes they have anxiety, but this must be a diagnosis made after all the other causes are thought about. When someone is diagnosed with COPD, we usually initiate treatment with steroids given a higher dose and in intravenous form, nebulizers which are given with greater frequency and possibly higher doses than used on the outside, and antibiotics. Oftentimes we'll need to give more supplemental oxygen than the patient uses normally, and of course we need to be careful that if we give them too much oxygen, they will in turn retain carbon dioxide, which will worsen the situation. The other thing that needs to be done is there may be other factors that need to be assessed, such as cardiac problems, problems with nutrition, and problems with things such as fluid balance. So essentially, this is some of the things to look at when you're dealing with a patient with emphysema. And a good and savvy nurse has a very important place as the first responder to the patient who has shortness of breath.